All right, Bismillah. Assalamu alaikum. Good evening to our IMANA community. I hope everyone is doing well. We are back with another IMANA education webinar for this month, and it being September and being National Substance Abuse Awareness Month, we are have a pleasure to have Sister Shannon McCrae here, who was going to be leading a discussion on a trauma-informed approach to treating substance use disorders. The purpose of this seminar is going to provide an overview of trauma-informed care, what it means to utilize this approach when treating patients who are diagnosed with substance use disorders. And this webinar will also plan to discuss trends related to the treatment of substance use disorders, along with ethical considerations for providers. Participants will learn about trauma-informed interventions and resources that they can immediately put into their work. As I mentioned, our speaker for this evening is Sister Shannon McCrae. She is a licensed clinical professional counselor and certified alcohol and drug counselor based in Chicago. A seasoned behavioral health clinician, Shannon has a decade and a half of experience providing trauma-informed care, specifically to those with substance use disorders, those involved in the justice system, and Black, Indigenous, people of color communities. Shannon believes in providing gender-responsive, trauma-informed, socially just, and culturally competent care, and offers professional development and continuing education through her company, AMEL Education, to ensure other clinicians are doing the same. She is also the Associate Director of Behavioral Health at the Inner City Muslim Action Network, IMAN, and enjoys collaborating with other behavioral health providers who are aligned with social justice-oriented healthcare. This is our first educational webinar through IMANA, where we are covering a very sensitive but important topic. So on behalf of the IMANA community, we would like to thank Sister Shannon for sharing her time and her expertise on a very important topic that for many within the medical as well as the general audience will very much appreciate. So on behalf of IMANA, thank you for being us, and please get started whenever you're ready.
Thank you so much. Assalamu alaikum to everyone. I am Shannon, and I will be presenting this evening on trauma-informed approaches to treating substance use disorders. As was just mentioned, this is the webinar overview, and I really want to open up with the question of, what's happened to you? That is really what we are talking about when we're talking about a trauma-informed approach. A lot of times in healthcare, we really, talk about what the problem is, what the chief complaint is, the chief concern, the symptoms. And yes, all of that is important, but what a trauma-informed approach really seeks to address is like, what's happened to you? What, before you came into this exam room, before you came into this therapy room, what has happened to you? And so by the end of this workshop, this training, hopefully we will all walk out as very trauma-informed providers, at least a starting point if we're not already doing that, to address, this question. So to go back a little bit, yes, I am the Associate Director of Behavioral Health at the Inner City Muslim Action Network, also known as IMAN, which is a federally qualified health center based in Chicago. Really, this kind of mission and value statement helps to kind of frame why trauma-informed work is so important. So at IMAN, we believe that high quality, accessible, dignified healthcare is a basic human right. The IMAN Health Center provides culturally aligned healthcare to structurally disadvantaged communities and seeks to enrich the health and well-being of patients by providing integrated medical and behavioral health care. So as I mentioned, we are a federally qualified health center located on the southwest side of Chicago in the Chicago Lawn neighborhood. In 2022, we serviced about 2,100, just over 2,100 patients. 89% of our patients are considered low income, and 75% probably more than that actually, but 75% officially identify as coming from Black, Indigenous, or people of color communities. So as I'm kind of going through the presentation and giving like examples and case studies, just, keep those statistics in mind because it will kind of help frame what we're doing. All right. So when we talk about trauma-informed care, kind of the principles, the guiding principles that we want to really keep in mind and put at the forefront are these four here. And these are adapted from SAMHSA's trauma-informed approach, which is pretty much the North Star when we're talking about trauma-informed care. So what does it mean? It means to understand the impact of trauma, realizing that that trauma is widespread and it has impacted our communities, and understanding those paths for recovery. We also want to be able to recognize the signs of trauma. And that's not only in our patients, but in their families and in our staff, which is going to become very key a few slides later. When we talk about trauma-informed care, we're not only talking about the patients we serve, but we also want our entire organizations and our entire clinics to be trauma-informed. We want to integrate knowledge about trauma into our policies, procedures, and practices. Again, this is not just about what you do in that exam room or what you do in that clinical space, but it's also about the entire organization. And most importantly, we want to avoid harm. We do not want to re-traumatize patients, families, staff members when they come into our space. So the first kind of overarching principle here is safety. Trauma-informed means that our patients, as well as staff alike, feel physically and psychologically safe throughout the organization. And again, I really want to emphasize that this is not just for patients, this is for staff, colleagues as well, okay? We want to greet people with a smile, right? It seems so simple, but this can get lost, if you're in traffic, if you got a flat tire, if the Starbucks line was too long, right? You definitely can come into the space grumpy, right? And not fully present and not fully attuned to how you may be showing up. But it's very important, if we're being trauma informed, that we are showing up with a smile. We're greeting people. If people are sitting in the waiting rooms, we're saying good morning, introducing ourselves. Those are very simple trauma informed practices that you can implement. One of the things that we did at IMANA to create this sense of psychological safety is because we are in an area that unfortunately experiences a lot of gun violence. When we were taking temperatures at the door for entrance, we had the thermometers, the handheld thermometers that you would hold up to your foreheads. And some of our patients commented that that was very triggering, right? Again, coming from a community with a lot of community violence, gun violence, we took that into consideration, and our security team, they stopped using those handheld thermometers, and we used the stand-up thermometers that you just stand in front and it kind of scans your face and takes that temperature that way. So again, really just being attuned to what makes our patients feel physically and psychologically safe. And then if we really remember that substance use disorders are medical diagnoses, right, and not just like moral failing, if you have that approach when you're working with your patients, that definitely helps to, engage that sense of psychological safety. Another principle that we want to implement when talking about trauma-informed care is trustworthiness and transparency. This means building and maintaining trust along with decisional transparency. So, this concept of do no harm, right? We want to, again, not be re-traumatizing folks who are coming in. Some examples of how you can build trustworthiness and transparency. Make sure as patients are filling out consent forms that you're thoroughly explaining those to them. You're explaining what all the bullet points mean, and you're explaining it in language that they can understand. Appropriate use of self-disclosure. A lot of times in substance abuse, even in my own career, I've had patients ask me, what do you know about, being strung out? What do you know about, throwing up, being on, withdrawing from heroin and things like that? And I don't have that personal lived experience, but it's okay to kind of talk that through with your patient, and use disclosure in appropriate levels and appropriate forms to build that trust and that rapport. And without being defensive. Early in my career, I definitely was defensive, and I say, no, I never had that, but, and I was very defensive. People are asking those questions to make sure that you can help them, right? They want to know how qualified you are to help them. And you don't necessarily have to have a lived experience of substance use disorders in order to be able to, be beneficial or to treat. And so that's essentially what people are asking. Another way to build trustworthiness and transparency with patients is to remind them that you are there for them. A lot of times with like mandated patients who are mandated from probation, parole, various supervision agencies, I have to remind them, you're my patient. The patient is not the probation officer. It's not the, whoever. You're my patient. And so, no, I'm not going to lie. No, I'm not going to sign off on anything that's not, that didn't really happen. But them just kind of understanding that you're on their side and you want to help is definitely one way to incorporate trauma-informed care. The next principle is peer support, and this means that patients and staff with lived experiences are integrated into the organization as a whole and seen and treated as integral to service delivery. So again, not everyone on your team has to specialize in substance use disorders or the treatment of substance use disorders, but what you really do want to have are staff who have some knowledge, who have some lived experience, and not just as tokens. We want them to really be integrated into the experience, into the decision-making, having ownership of perhaps, running a peer support group, running, community education workshops. People with lived experiences really do have a lot to offer, especially as it comes to substance use disorders. I remember when I was in training for my certified alcohol and drug counselor certification, the majority of folks in that training were people in recovery. And I think that is often true in the substance abuse world. People have this sense of really like wanting to pay it forward. And so that's why you see Alcoholics Anonymous and Narcotics Anonymous. Those are really peer-led. And so it's really important to incorporate those voices when we're talking about this work. The next principle is collaboration. Making sure that power differentials are leveled to support the shared decision-making. We really want to hold to the principle that the patient is the expert on his or herself, get consensus in treatment planning and options. Just making sure we're explaining thoroughly what options are, getting consent from the patient, and again, consensus. And also consulting with peers and other specialists from other clinics, other departments, other organizations to find out what some recommendations are and best practices are. It's always good to have, those kind of partner agencies, partner staff members, perhaps in different divisions or different departments who you can collaborate with and consult with, case consults, right? I have this patient who's exhibiting XYZ. What do you recommend? This is what I've tried. It's not working. Do you have any suggestions or recommendations? So collaboration is definitely key, not only with patients, but again, with other staff. The fifth principle is empowerment. And this is a belief in resilience and the ability to heal from trauma with recognition of patient and staff strengths, okay? So we really want to have an emphasis on healing and holistic care. This idea that, again, this is a substance use disorder that is a diagnosis, but there's many different things that contribute to why a person is showing up in that clinic, right? And so how are we getting our patients involved in policy making? I know, again, from IMAN, we're a health center, but as a larger organization, this is something that we engage our patients in. We take bus loads of people from the community and from the clinic down to Springfield, which is the capital here in Illinois, right? When it's time to lobby and get signatures and, vote on things. And so making sure that your patients and community members really feel empowered to change the circumstances that, all kind of lead into the same cycles that we oftentimes see when we're working in communities. We want to also make sure we're catering to different learning styles. Some patients, some staff members, right? They may be more inclined to receive information when it's written, right? And so they need very written instructions or, a written treatment plan. Whereas some other patients or staff members, maybe they need to hear it. Don't give them a piece of paper, right? Because they need to hear it and really be able to do that verbal engagement back and forth to be able to take in the information. And so that's important, again, to make sure you're tailoring your communication style and your teaching style to who is in front of you. And then also just sharing success stories. A lot of times we talk to our patients about the negatives and the consequences and, if you don't do this, this is going to happen. But let's also remember to be trauma informed by sharing success stories. A lot of times with substance use disorders, patients are feeling really hopeless, really overwhelmed, and just being able to hear success stories that, people have overcome this, this treatment has worked, this, therapist has worked, this medication has worked. Sometimes they really need that to kind of push them over the edge of hopelessness to now being hopeful. And then finally, the sixth principle is humility and responsiveness. And so this is when we acknowledge, right, our biases. We acknowledge that we all operate within oppressive systems, and that there are historical traumas that have happened to our patients, that have happened to our colleagues, and we're not afraid to kind of interrogate how those things show up in our patients' health, how they show up in our colleagues, engagement and things like that. And so you really want to talk about and acknowledge those biases, those oppressive systems, right, and traumas. When we're talking about substance use disorders, substances didn't just pop up, right? Talking about that, where did the substances come from in certain communities, talk about the disparities that we see, with certain substances in certain communities, talk about those health outcomes, with certain, populations when using substances. These are ways to be trauma informed because then you can really tailor your treatments to the populations. If you have to know the populations that you're working with, know the demographics, know how things are affecting them in order to be able to treat them effectively. And then, just the sense of humility. A lot of times, in healthcare, people have studied for a long time. They've invested financially into their education and training. They have invested emotionally, right, and intellectually. And so that is something to be proud of, for sure. But we also need to remember that just because we have a degree, just because we have years of experience, it doesn't mean that we're necessarily the most knowledgeable when it comes to certain things, right? And so there are plenty of times when a patient will be telling me about a new drug, and I'm a licensed counselor, certified alcohol and drug. I'm like, what is that? I never heard of that. And that's because I don't know everything, right? And so there's a sense of humility that even as providers and as clinicians that we have to make sure that we, are constantly growing and learning, and not just from our colleagues, right? People that we consider our peers, but again, also our patients. So what are some of the benefits of being trauma informed? Okay, so some of the benefits are that patients engage more fully in their healthcare. Again, if they have built relationships and they feel that there's a rapport and that they can trust you and that you have their best interests in mind, they're willing to engage more fully. Developing the trust in relationships, as we just said, and then it improves long-term health outcomes, right? If you can really gain that patient, they can become very loyal to you, right? They become loyal, they trust your recommendations, they're less hesitant. And so all of this with good care, it really improves their health outcomes. And then again, why the emphasis on making sure staff are also supported in this trauma-informed approach is because it really helps reduce burnout among healthcare providers, right? So when we're talking about physical space, for example, you want that to be warm and you want that to be inviting. This not only makes it welcoming for patients, but also for staff, right? And that's one very simple example. But when people have a sense of safety, it makes the whole operation run more smoothly. All right, so something that I want to point out as far as trends when it comes to trauma and substance abuse is to really talk about that link. Okay, so when we are talking about substance abuse, trauma is actually one of the co-occurring disorders with the highest prevalence rate for patients in substance use treatment. Okay, individuals with a diagnosis of PTSD engage in treatment for substance use disorders at a rate 5 times higher than the general population. 5% of people who have survived abusive or violent traumatic experiences report problematic alcohol use. Men and women who report sexual abuse have higher rates of substance use disorders than men and women who do not report histories of sexual abuse. And adolescents with PTSD, post-traumatic stress disorder, are 4 times more likely to experience alcohol abuse, 6 times more likely to experience marijuana abuse, and 9 times more likely to experience hard drug abuse. And with all statistics, right? These numbers are probably much higher, right, than we even know. And so why this is important to know is because there is a very clear link between a person's trauma history and their substance use history, okay? So it's therefore pretty much impossible to effectively and holistically treat substance use without being trauma informed, without understanding a person's trauma history. It's similarly almost impossible to treat a person's trauma if they're presenting with substance use and not treating that, right? So they really go hand in hand. With substance abuse and with trauma alike, there's a lot of shame, there's a lot of stigma, there's a lot of resistance, a lot of denial a lot of times. And so what we have found at IMANA is being able to really frame trauma care and substance abuse care as just general health care, right? Like we don't even have to call it trauma. We don't even have to call it substance use. Let's just call it, we're treating your health. We're treating you holistically. And so some of the ways that we've been able to kind of work around or reframe this work is by making sure that we're screening and targeting people at their medical visits, right? And so we're really embedding this trauma-informed care, the substance abuse treatment into our screening for medical visit, right? People are more likely to come to their medical visits than they may come to a substance abuse treatment, visit. And so once we kind of get them in the door that way, really embed by being trauma-informed and warm and welcoming and all that, to be able to then, refer them and do warm handoffs for our behavioral health department to discuss the things like trauma and substance use. So it's really this idea of integrated care that you're not going to do justice by just treating one or the other. They really need to be treated together. So I have a couple of case studies that I'd like to share just to get us thinking about, again, those principles, those kind of North Stars, those approaches to when we see patients in front of us, what are some things that we should be thinking about? What are some things that we should be considering? So this case study, Sara is a 32-year-old Palestinian woman in your clinic who frequently misses her appointments and at other times shows up without an appointment at all, often in crisis. She has a 2-year-old son. She currently uses alcohol and tobacco and has started to use street drugs, including her friend Xanax prescription and cocaine. Since you've developed a therapeutic relationship with her, you learn that she grew up in a household with a violent stepfather who frequently assaulted her mother, her siblings, and herself. Although her mother is no longer with the stepfather, the impact of his violence presents itself on a daily basis as Sada struggles to cope with the trauma she experienced. She left school early, has few marketable skills, and has never been able to hold a job for more than a few months. Sada receives $400 per month from public assistance benefits and has no money left for food or other essentials at the end of the month. She is currently in a relationship with a man whom you suspect may be violent. Okay, so Sada obviously has a lot going on. So what I want us to, as we're kind of conceptualizing this case, is to go back to these principles, right? Understanding the impact, recognizing the signs, integrating our knowledge, and avoiding harm. These are the concepts to always consider when you're trying to be trauma informed in your treatment approaches. So if we're understanding the impact, we're understanding that Sada had a history of domestic violence in her childhood home, which we know adverse childhood experiences, abuse, domestic violence, that all affects brain development and that all can lead to trauma, right? So understanding the impact of that. Recognizing the signs of trauma. Sada, frequently in crisis mode. Her socioeconomic status puts her at risk for vulnerability, exploitation, right? Her current risk of intimate partner violence, right? The partner that you suspect is violent with her. These are all signs as Sada says these things in her visit, as you observe these things, just visible observations. These are signs that you should be recognizing. Then you want to integrate the knowledge, okay? You understand the impact, you recognize these signs. How do we integrate that knowledge into our treatment of Sada? You want to, again, follow those best practices in treating co-occurring disorders. So yes, her cocaine use, her unprescribed Xanax, right? Like all of those things are important, but you also need to treat the trauma. And if it's not you as the provider who's rendering those services for trauma, you want to make sure that you have collaborative care referrals, either within your own clinic or organization or with partner organizations to be able to do that. Because you can put Sada in all of the detoxes, you can give Sada all of the medications, you can do all of that, but if the trauma, the underlying trauma is not being addressed, Sada will be in relapse sooner than we realize, right? And being culturally competent, what does Sada's Palestinian culture have to do with how successful she can be in treatment, how supported she is in treatment? Are there any cultural implications that you should be aware of? Is this a big taboo in Sada's culture to, have a substance use disorder? And then I'm sorry, going back to the collaborative care referrals, again, if it's not something that you do at, within your scope of practice or even at your organization, you want to make sure that you have referrals to wraparound services. So in Sada's instance, it might be therapy, it might be job training, it might be childcare, it might be going back to school for a GED, right? Or some tutoring. And this is where that collaborative care is very important. A social worker can really help link Sada to these needed services as a complement to any of the medical care that she might be receiving. And then again, we want to avoid harm. We want Sada to feel physically and psychologically safe, not judged, not, oh, you're a Muslim, right? Why are you doing XYZ? Because that does not make anyone feel safe and that does not make anyone feel willing to open up. Being trauma informed is, hey, this happens. How can we resolve this? And then a key point with Sada was having the 2-year-old son. Depending on where you are, There may be laws that say, you have to report this to, child or family services. And you definitely want to operate within the scope of, whatever laws and whatever code of ethics and all of that. But we also, again, being trauma informed, is the most important thing to report Sada for her substance use, or is it to get her help for the assistance that she needs and being able to safely and healthily raise her 2-year-old child, right? And so these are some concepts that we would consider if we're implementing trauma-informed care with that case. All right, so we have another case study, and this is the case of Omar. So Omar is a 55-year-old Black male who recently experienced a physical back injury after a serious accident in the warehouse where he works. He's able to perform some amount of activities of daily living, but is temporarily on disability while he recovers. Due to his chronic back pain, his previous doctor has prescribed oxycodone, which he uses occasionally, as needed, as prescribed. He is taking it as prescribed. However, he also uses marijuana daily because it helps with the pain as well. He's recently divorced, lives alone, and is finding it hard to cope with this loss. Omar presents at the clinic reporting increased pain. During your conversation, you discovered that he is gradually increasing the amount of marijuana he's using to combat his pain and feelings of isolation. So again, keeping these principles in mind, if we're implementing trauma-informed care, we want to understand what's happened, right? What's happened is the work accident and injury, which can be very traumatic depending on what that entailed, okay? The impact of that is the trauma. Recognizing the signs. There's not only the loss temporarily of a job, right? The loss of the full function of his body, but there's also the loss of a relationship, okay, with the divorce. Isolation, he reported feeling isolated, and then of course, pain, okay? So these are signs and symptoms that we recognize, and we're starting to conceptualize, put the whole picture together for how we're gonna treat the whole person. Now we wanna integrate that knowledge. Again, we should be assessing for the emotional toll that this accident at work had on the patient, because we know the physical toll, right? He's in pain, he's out of work temporarily, we know that, but what is the emotional toll of that injury? How serious is the injury? What's the prognosis? How has this impacted, his self-perception, right? Those are the types of things you want to interrogate when you're, having this idea of integrated care and co-occurring disorders. Collaborative care, again, what type of referral are you making? It sounds like you need to make a referral to a therapist to address, the issues of isolation, the loss, the dissolution of his marriage. Therapy can help to kind of process that and talk through what life looks like after divorce. And then cultural competence, right? What things do we need to consider with Omar being a Black male? We already know that Black males tend to be dismissed when they are coming in for pain because they are perceived to have higher thresholds of pain. We know that a Black male coming in asking for pain medication might also be seen as drug seeking, right? And so we want to make sure we're checking our biases and we are not perceiving this male to have higher thresholds of pain, and therefore we do not want to treat his pain because we think he's Superman or because we think he's drug seeking. We want to be culturally competent and explore, what treatments are available to address the pain. Okay, so those are just two very simple case studies that I wanted to share to get us, again, just kind of walking through understanding impact, recognizing the signs, integrating knowledge, and avoiding harm. Those are the kind of steps that we want to walk ourselves through when we are talking about trauma-informed care as it particularly relates to substance use disorders. Some other trauma-informed practices we can implement are through screening and assessment. You want to have skilled practitioners in the treatment of both trauma and substance use disorders. So this does not mean that every single person in your clinic or at your practice needs to be trained specifically in trauma or trained specifically in substance use disorders. You can have generalists, okay, but you want to make sure there's a certain level of training, right? So that they're able to screen and properly assess for substance use disorders as well as trauma. You want to make sure that your staff is able to sensitively and comprehensively identify patterns and not be afraid to bring this up, right? If we're noticing patterns, bringing it up is not the issue. It's how we bring it up. Again, we can't treat something, we can't intervene about something that's kind of like the elephant in the room and that we're not addressing. So being able to identify patterns, saying things like, I'm noticing this, or, I'm wondering this, or can you tell me about this, without being accusatory, can go a long way in getting information from patients. And then under screening and assessment, again, just knowing when referrals are indicated, being proactive in identifying referral partners who are also trauma informed, so that if it's not something that you feel comfortable or competent addressing or even capable, right, of addressing within your clinical practice, having referrals is completely fine. Then within treatment, for treatment planning, you want to discuss the impact of substances on other factors. So providing this level of like education, right? Like we're not just talking about like substances and how heroin's terrible, but let's also talk about how this is impacting your sleep and it's causing you anger and it's giving you depression and increasing your anxiety. Let's talk about it in the full scope. Okay. You want to also provide that education, that psychotherapy, the peer support, and medication. So we want to treat the whole person, kind of attacking this from a number of different areas. And so really combining talking to the patient about substances, how they affect the body, incorporating that psychotherapy, right, with the therapist, peer support, right, medication, all of that together increases a chance of recovery. And then again, this emphasis on collaborative care. Some additional steps and interventions, education, okay, ongoing training and staff, ongoing training for staff at all levels. So, right, this type of workshop. So thank you to IMANA for recognizing the importance of ongoing training. This is very important. And this doesn't have to be, a week-long conference. This could be an in-house, 10-minute, sharing of a resource or sharing of a new intervention. It can be, off-site continuing education time as well, but making sure that staff at all levels have training that's relevant to their provision of care. The physical environment, you want to have a dignified space for patient and staff, okay? Again, you want to make sure that the area is nicely decorated and, you don't have to go all out with like designer, we know that's not always in the budget, but just having a nice dignified space where people can escape the environments that they're coming from, right? That are not, when we're talking about substance use disorders, that are not always nice, right? People literally may be undomiciled, living in some really rugged conditions. Having a nice, comfortable, warm space that they can walk into to receive care really can make the difference. Accessibility. So yes, the physical accessibility of the buildings, right, and our rooms and things like that, but also just like what hours are we open? Are we open on hours that are better for us as clinicians, or are the hours that we're open actually the hours that the patients who most need our help are available, right? Do we have weekend hours? Do we have evening hours? Things that make our services accessible on a number of levels. And then representation. So not only do we want representation, again, lived experiences from staff, We also want to make sure that the imagery that we have in our clinics and our practices, the literature that we have, there's some representation. And this does not just mean, a racial representation or ethnic representation. It also means if you are in a medical practice or medical clinic, do you have pamphlets and do you have flyers and do you have things that also, don't just talk about hypertension and diabetes, but that also talk about substance use disorders, right? We want to normalize that this is a medical condition and this is a medical clinic where you can receive treatment for that. Safety, okay, safe security procedures, what is happening at your clinic or practice in terms of how people are greeted, how people come in, are they walking through a metal detector, or they get wanded with a metal detector, things like that can make the difference in do people feel safe or not, right? Is this trauma informed or not? Again, where IMANA is located, walking through a metal detector is the norm, right? In many places at our clinics, that's not something that we do. We do have security officers who are posted in all of the areas of the clinic entrances, but they are greeting people with a smile, a hello, a good morning, right? They are the first people that our patients see. And so it's very important that, again, all levels of staff are educated on what it means to be trauma informed. Just showing a genuine concern and warmth from staff to patients. Again, a simple good morning. If someone's waiting in the waiting room, have you been helped? Have you been checked in? That goes a long way. Taking a harm reduction approach. We know that not everyone who we see in our clinics for substance use disorders is at the point of wanting to stop using. And that's okay. We can take a harm reduction approach that also increases that sense of psychological safety to let them know we can take baby steps, right? Partners, we went over that. Make sure you are vetting people that you're referring your patients to. You want to make sure that you're not sending them to a building that's closed. We want to make sure that we're not sending them to a place that doesn't accept their insurance. We want to make sure that who we're referring to are also representative, right? Are also trauma informed. Collaboration. The patient is the expert on his or her life and knows the most about what has and hasn't worked. And we'll talk on the next slide about what SFBT and MI are. And then feedback, okay? We really want to give patients a sense of autonomy, make sure they understand they have involvement and voice in their care, and receiving input from those with lived experiences as we're building out our protocols, our programming, our policies, and our services. And then I know we are coming up on time, so this is almost the last slide. I want to just go back to this idea of collaboration in working with the patient. These are two kind of theories, two approaches that you can use. The first is called solution-focused brief therapy, and the second is called motivational interviewing. Evidence-based, very useful when working with substance use disorders. In SFBT, there's an emphasis on the patient's ability to solve problems versus like why or how the problem is created, right? We're not concerned with why or how, we're concerned with how can the patient solve this problem. How we do that is through goal clarification, asking the patient, what is it that you want? Asking what's called the miracle question in therapy, if you could snap your fingers and everything would happen the way you wanted it, what would that look like for you? Asking exception questions. So tell me about a time you remember where you didn't have to get high, right? Was there ever a time you felt happy without the use of substances? Those are exception questions that are specific techniques within SFBT. And then scaling questions, right? So on a scale of 1 to 10, tell me where you are today. And then asking follow-up questions. Okay, so you said a 4. What makes it a 4 and not an 8? Okay, those are all techniques within solution-focused brief therapy. And then motivational interviewing is a set of techniques that really encourages patient motivation by resolving ambivalence, okay? So if we know about the stages of change, which are pre-contemplation, contemplation, preparation, action, maintenance, and then some people say relapse, How do we move a patient from being ambivalent, in denial, not seeing their substance use as a problem, to, okay, yes, this is a problem, and now I'm ready to take action to change that. In motivational interviewing, there's an acronym called OARS, which stands for open questions, affirmation, reflective listening, and summaries. Okay, so you want to do things. Oh no, I didn't put it on here. You want to ask questions like, help me understand, or, what have you tried before to make a change, or what do you want to do next? Those are open questions. Affirmations could be something like, I appreciate your willingness to come in, to discuss this. I know you took 2 buses and a train to get here, right? Thank you for making it in this weather, or that's a good suggestion. Those are simple examples of affirmation. The R for reflective listening, it sounds like, or what I'm hearing, or simply repeating or paraphrasing what a patient says, so that they understand that you're listening and so that they have a chance to correct anything that's not correct. And the S stands for summarizing. So you could say something like, here's what I heard. Tell me if I missed anything. Let me see if I understand this correctly. Or, is there anything you want to add or correct? Those are, again, very simple ways to incorporate ORs. And then rolling with resistance. Again, taking that harm reduction approach. It's okay if a patient is not ready to just cold turkey abstain from substances. How do we roll with that resistance without becoming offended or, becoming aggravated with the patient? And then again, developing discrepancy. It's okay to point out the inconsistencies, right, with what a patient is doing and what a patient says they want as their end goal. It's okay to point that discrepancy out, but we want to do that in a trauma-informed, very sensitive way. So that concludes the information portion that I have, and I would love to open it up for any questions that might have come through, any comments, any feedback, anything. I have talked enough, so I'm happy to open that up for anyone else who would like to jump in.
Jazakallah khair, Sister Shannon. This was extremely informative. You offered a lot of helpful trauma-informed tips for the medical community to navigate helping patients with substance use disorders, especially regarding Muslim patients. So thank you for that. This is a tremendous resource and beneficial resource that a lot of medical professionals can refer back to with this recording. So I recommend that you share this, especially with the free clinics in your area. There's a few gems. There's a few things that I actually wanted to highlight. The starting question of what happened to you, it really implies that drug use and abuse, it's a symptom of a greater disease, that it's a medical illness. Like, as you mentioned, it's not a moral failing. I like that you talked about the concept of humility, that just because a person has a particular degree or an educational background, that ultimately the patient is the expert on themselves and also even on this disease. So listening to them is essential and important to their well-being. You talked a little bit about the tip on empowerment and acknowledging the strength that comes with the patient choosing to come to the clinic, and giving them tools to make change in the legal sphere was very interesting. You also talked about the importance of screening substance use at free clinics in order to treat them holistically, such as like literature within those facilities as well. And I think the last thing that really kind of really stood out was that concept of the harm reduction, that it doesn't have to be this all or none, that you can take baby steps and that can be a symbol of even success within that person's life. So these are just a couple things that I wanted to highlight that I really appreciated. There is a question that I have Now, when you look at the like the 12 steps of Alcoholic Anonymous, it does include some aspects of spirituality within that treatment. I think it's step 11. It talks about using prayer or meditation to connect with a higher power. I was wondering, just from your own professional experience, when it comes to patients who are Muslim, do you incorporate faith in the treatment? And do you find that to be a like a door that they tend to want to walk through, or, how do you navigate through that?
Sure. So I always let the patient kind of dictate how much or how little we incorporate that. So there are some Muslims who come in for treatment, and this is like, oh my goodness, nobody can know about this. This is terrible. I'm a terrible Muslim, right? And so I don't push it, right? But I do, bring that up. Okay, well, there's always redemption. There's always, forgiveness, right? So like, let's talk about, no, you're not a terrible Muslim. Like, how do we get you to being the kind of Muslim that you want to be, right? So we do talk about that. We do. I will say, in my experience, it also, and this is the larger culture in general, right? Substance use in popular culture is just there, right? It's in the music, it's in the TV, it's just a thing. And so I do see trending that there are Muslims who it's normalized, right, to smoke weed or to drink. And so the opposite, right? Like they don't think of it as a taboo or a faux pas or anything, right? Because it's just everybody is doing it. So I follow the patient's lead when we're talking about it. If they want to bring spirituality into it, absolutely. If it's not, I don't.
Gotcha. I like the case study that you mentioned about the Palestinian woman as well, because it kind of highlighted a little bit how the Muslim community may look at Muslims with drug use, in a stigmatized fashion. And so maybe patients choose, or, coming forward or seeking treatment out of fear of being ostracized. And I know that that can be an element of part of the treatment plan as well. But, it's something where it's case by case. It depends. Another question is, how do you think that those with addiction feel about coming to Iman? Coming from Chicago, there's a lot of different rehab options. So whether someone's Muslim or non-Muslim or what have you, what is something that kind of stands out unique with Iman that may, have people gravitate towards going to that area or that organization?
Yeah, so I think it's the fact that we were trauma informed before like the trauma informed label, right? Like we really encourage people to come and just receive the help they need, non-judgmental, right? There's no shame in getting help. And this idea that we're really treating the whole person. You can literally come to Iman, come see your medical provider, come see your behavioral health therapist, go into our ceramic studio with the arts and culture department, hop on a bus, go down to Springfield, right? And, be lobbying, the legislators, right? Like there's so many things that we do to really emphasize this idea of holistic wellness, right? Because again, we can treat people's medical conditions, but if they don't have a sense of connection to culture, right, and art, if they don't have a sense of connection to the systems, that they live within, right, whether that's legal systems, any of that, political systems, right, it's still not all going to fall into place. So I think that us being trauma informed and us really leading with that and in the different aspects, I think that makes people feel very welcome and very comfortable and very safe.
That's incredible. I actually grew up in Illinois. I'm born and raised there. I live in Michigan now, but I'm very familiar with the work of Iman, and it's incredible how it's even crossed state lines. Like
Mashallah, mashallah.
it's an organization that people on a national level know about. You really are really paving the way that a lot of people can replicate within their own community. May Allah reward Iman immensely, and may it be a means of benefit to our community and continue to do so. Thank you so much for the work work and the dedication that you do as well, Sister Shannon.
Yes.
We, as on behalf of IMANA community, we look forward to having you back in the future to educate our community as well. But I'd like to thank you and hope again that for anybody who is interested in learning more or reaching out, Sister Shannon's recording is going to be posted on the Iman Education website and YouTube channel probably this week. And please share it with others. Sister Shannon has also has her contact information as well through this recording if you would like to reach out, or you can also reach out to Iman as well. Any final thoughts, Sister Shannon, before we close for tonight?
I just would like to thank you for having me and thank you for really amplifying this very important topic for healthcare providers because at the end of the day, we're all just trying to do the best we can. And so these opportunities make that a possibility.
Absolutely. Absolutely. Couldn't agree more. Well, thank you all very much for attending, for all of those on Facebook Live. And we look forward to seeing you at the next Imana Education webinar in the future. Again, thank you to Sister Shannon, and we hope you guys all have a wonderful evening. Assalamu alaikum wa rahmatullah.
Wa alaikum salam.